Okay, welcome back, guys. We're going to continue with our respiratory system content. In relationship to respiratory system, let's see where we left off. We should be right down. Oh, a little too far. Here, we were talking about non-respiratory air movements in our last video. So let's continue onward, and now we're going to be talking a little bit of math. I know math tends to freak people out, but this is really simple stuff. So let's talk about respiratory volume and capacity. So let's get into that. So first of all, normal breathing, when we're breathing casually, right, which is what we'd expect for most of our day, we typically move somewhere around 500 milliliters of air. So 500 mils. Remember, a milliliter is a thousandth of a liter. So 1/1000 if you're thinking on a fraction basis. Now, on that subject matter, the amount of breath or the amount of air that we breathe normally is going to be referred to as our tidal volume. Tidal volume. Now, there are a number of factors that can affect respiratory capacity, which we're going to talk about in just a second. We do need to know these four factors, though. So let's get into that ourselves. Person size. Straightforward enough. If you're a larger person, you're going to have a larger set of lungs than someone who's smaller. That makes sense, right? Nothing too dramatic there. The sex of the individual also plays a factor here too. So somebody who's a male is traditionally speaking going to have a larger set of lungs or larger respiratory capacity than a woman. Is that always the case? Of course not. There are many times where a woman is going to have a larger respiratory capacity, but if you're thinking of evolutionary purposes, hunters and gatherers, men needed to have a larger set of lungs for that reason. Age. Typically speaking, your sweet spot for age is going to be like anywhere from your teenage years all the way through your 30s and 40s and up to 50s. When you're too young, your body is just physically too small. You can't really breathe that effectively. When you're too old, your body struggles to breathe, not because the lungs are small or are shrinking or anything like that. It's harder to breathe. Finally, physical condition. In regards to physical condition is not literally just stating how in shape you are or your physique. There's a common misconception with that, and we'll learn more about that in muscular system. Being in shape doesn't necessarily mean that you have a perfect physique, like a model, for instance. So that's something we'll debunk a little bit more. The physical condition certainly can be exercising. What are some exercises that we expect that can help boost your respiratory capacity? Running, jogging, biking, even walking, swimming, a ton of different sports as well. So what's the common theme for all those things? Those are all exercises that are high on cardiovascular activity. They make you raise your heart rate and maintain your heart rate at a higher level for longer periods of time. Now, that said, physical condition is not just exercising. Physical condition can also be singing or playing instruments like your wind and some brass instruments, right? So those type of things also can help boost your respiratory capacity, dramatically speaking. Finally, you have what's called residual volume of air. That residual air is just left over in the lungs. It's about 1,200 mils or 1.2 liters. That's left over in the lungs, as we were just mentioning. Okay, moving on to our next slide. Okay, IRV versus ERV. IRV stands for inspiratory reserve volume. It's the amount of air that can be taken in forcibly over the tidal volume. So this is taking a deep breath in, as much air as you possibly can. This is typically between 2,100 and 3,200 mils or 3.1 or 3.2 liters. That's a lot of air, especially compared to the 500 mils that is a tidal volume. So you can take in a lot. ERV, on the other hand, is going to be expiratory reserve volume. That is the amount of air that can be forcibly exhaled. So as far as ERV is concerned, that's approximately 1,200 milliliters. Now, here's the thing. You can breathe in a lot of air, but you can't breathe out as much. I wonder what's going on. The idea here is that you breathe in all this air, and quite a bit of it is going to be entering your blood through what we referred to in a previous video as external respiration. So the remaining amount of it is just going to exit out of your lungs and back into the atmosphere. Okay. Moving on next. Respiratory volume and capacity. I already talked about this, right? Residual volume, it was two slides ago, so we don't have to get too crazy with that. But we do have this extra air left over in our lungs. Oftentimes, I like to mention that, in cartoons and in movies and video games where you have the final moment of a character and they're saying their last breath and then they just topple over. That's pretty accurate. Obviously, it's romanticized and exaggerated for film, but it's pretty accurate that when we pass, any leftover air is going to exit out. So that is expected. Okay, this is the whole reason why we needed to understand these values that we were talking about earlier. It's to learn what's called vital capacity. So we definitely need to know this stuff. Vital capacity is the total amount of exchangeable air. How do we calculate vital capacity? Simple. It's a math formula. And I know math formulas can be tough, but this is simple, right? You're just adding stuff up. Tidal volume plus inspiratory reserve volume, or IRV, plus expiratory reserve volume, or ERV. Those three together give you your vital capacity. Now, on the test, I may ask you a question where I give you the vital capacity and I ask you to solve for one of the others. That's simple algebra, right? You're just solving for X. That should not be a problem. Dead space. Dead space is the air that is remaining in the conducting zone and never reaches the alveoli. So this is stuff that you breathe in and it enters your nose, enters your nasal cavity, down the trachea, through the pharynx, through the larynx, all these structures, but it never actually makes it to the alveoli. So that's why we call it dead space, which is pretty interesting. Okay, functional volume. This one's a pretty interesting one as well. Functional volume is going to be, let me go ahead and start this, the air that actually reaches the respiratory zone. So this is the air that you breathe in that finally actually does reach the respiratory zone, aka the alveoli. The alveoli is the area where the gases will transfer over into the bloodstream. About 350 mils are going to reach this. So if we do some basic math and we think, okay, well, 350 mils are going to reach the alveoli. When we have our tidal volume, that's going to be about 500. Oh, sorry. I didn't realize I was pressing down on the arrow keys. Let me get back to where I was. There we are. One more time. So 350 mils are going to be how much functional volume. But we breathe in roughly 500 mils in a casual normal breath, which is your normal breathing. If you do the math for that and you convert that to a percentage, that gives us about 70% efficiency. So that means that with every breath, casual breathing, inspiratory breathing, so harder breathing, you take into your blood roughly 70% of what you're breathing, which is pretty effective. Finally, how do we measure respiratory capacity apart from just doing some mathematics? You can also use a device that if you have any sort of lung condition, you're probably already familiar with this or have experienced this before. It's called a spirometer. A spirometer is this device that you breathe into and it has like a little hockey puck in it that you need to raise the hockey puck up to a certain area. If you can do that, that means your lungs are functioning fine. If you can't and you struggle to do that, that means you may have a lung condition or something like asthma or something along those lines. Here we see the respiratory capacities. Once again, everything in yellow is tidal volume. So that's your basic, that's your normal breathing. In this red color, that's your inspiratory reserve volume. So that's this massive spike. In this blue color, that's your expiratory reserve. So again, notice you don't have as big of a dip or as big of a leap as we expect. When you add those three together, that gets you your vital capacity. 4,800 mils, that's the average amount for most people, 4.8 liters. When you add the vital capacity to a residual volume, which is the extra air left over in the lungs, that gives you your total lung capacity. Respiratory sounds. How do we identify respiratory sounds? Use a stethoscope. It's a classic, iconic medical tool, medical device, right? So sounds are monitored with the use of a stethoscope. What sounds do we identify? Bronchial sounds and vesicular sounds. Bronchial sounds are going to be used to identify the air traveling into the trachea and the bronchi. So that's going to be a lot louder. Whereas vesicular sounds is going to be listening in for the soft sounds of the alveoli being filled with air. Where do we typically place the metallic part of the stethoscope to listen to the lungs? Your back. If you place it on the front, the problem is the heart's too loud and it would cause a little bit too much conflicting audio. External respiration. So this is just once again repeating some stuff that I talked about in a previous video. I really just want to emphasize one thing, and that's what I'm going to talk about in these last couple slides for this video today. First off, just a reminder, when it comes down to external respiration, it is the transfer of gases from the lungs more specifically from the alveoli, from the lungs into the blood. And vice versa, right? So what are we trying to get from the lungs into the blood? Oxygen. That's what we need, right? That's what keeps us alive. The alveoli will always have more oxygen than the blood. That makes sense because we're breathing in. Oxygen will move via diffusion towards the areas of lower concentration. That's how diffusion works. Pulmonary capillaries will gain oxygen. Sounds good. So you're getting the oxygen from the lungs, from the alveoli into the blood. On the other hand, carbon dioxide, you're trying to get it out of the blood, right? Because of your higher concentrations of carbon dioxide in the blood, you're going to try to force it out. That's the whole point. We don't need carbon dioxide. It's a toxin. Pulmonary capillary blood gives up carbon dioxide. Blood leaving the lungs is oxygen rich and carbon dioxide poor. That's stuff that we're going to learn more in detail when we do cardiovascular system and we learn the path that blood takes. Gas transport in the blood. This is once again emphasizing something that I'm just about to get to. Oxygen inside the blood is going to travel via a hemoglobin, a particular protein. We're going to learn more about that in cardiovascular system. A very little amount of it does carry through the plasma, which is a part of the blood. Carbon dioxide, on the other hand, is going to travel primarily through the plasma. It travels through what's called bicarbonate. We don't need to worry too much about that. That's some chemistry that you don't need. But a small amount of it will be carried on the hemoglobin. So what am I trying to emphasize here? What I'm trying to emphasize is that the relationship in regards to gas exchange between carbon dioxide and oxygen are opposites. We need oxygen in, you need to get rid of carbon dioxide. The oxygen in your blood goes straight to goes straight to your hemoglobin. The carbon dioxide in your blood goes straight to your plasma. So there's opposites. It's constantly an opposite situation that we expect and that we see, and then we're going to learn a little bit more about as we continue progressing through our material. All right. So that's where we're going to stop for today. Thanks, guys, for tuning in. I'll see you guys on the next one. Have a good one.